And thanks for the really kind introduction. And David has been from a very early on one of my biggest inspirations. So I always try to follow in his footsteps. So it's a real pleasure to present some of the work that my group has been doing in the context of sensing and behavioral health. And I want to start by acknowledging the students, the PhD students and postdocs who have been working in this space with me and have been instrumental in doing the work that I'll be presenting here. And I also wanted to kind of mention that I have a deep interest in figuring out how to take research into the real world. And as part of that, I've also been one of the co-founders of a mental health startup called HealthRhythms. And if you're attending this talk, you probably are familiar and keenly aware of how much we need to improve mental health care. And one of the fundamental kind of challenges has been measurement, right? We can't, we can't really fix what we can't measure, and reliably measuring behavioral health has been a continuous challenge. Often it's been very sporadic, very low kind of reliability across the board. But it's not a small problem. A lot of people suffer from behavioral health issues. Even before we even get to measurement, people aren't even diagnosed, and overall through whether it's caused due to poorly managed behavioral health and other consequences of having poor mental or behavioral health, the cost is really high. So there is a lot of opportunity to do better measurement, as well as making the system more scalable, efficient, and in a way cost effective. And the problem becomes even worse when we think about mental illness combined with chronic illness, and which is often referred to like mental health comorbidity. And there is high morbidity in pretty much all of chronic illness, and they lead to overall much worse outcome and become very costly. And I think this is an excellent place to kind of think about now as we are coming out of COVID, where almost we have had a shock to the system, where people have been forced to use certain technology, that we can try to think broadly about how technology now can play a role when now the door has been open, and particularly there has been a lot more openness across the board in remote patient monitoring and treatment. So, and the case can be made very effectively of why it can be really, from an outcome perspective as well as a cost perspective, it's viable. So I think one of the things that I want to mention, that probably now is the time that those of us who are interested in taking some solutions, research solutions into the real world, is to try to find ways to do that. This is the current state of the art when it comes to practice, right? If we think about depression, doing PHQ-9 is a screening tool or assessment tool that is tries to characterize symptom severity and overall kind of depression severity. One of the things that I always like to highlight is that most of it is about our behavior in the world, right? How we are going about and live our lives, our energy level and our sleep behavior, our eating behavior, how are we spending our time, and even just the aspect of psychomotor changes, like how fast or slow we are interacting with the world. And of course, there are aspects of our kind of thoughts and feelings which are very important, but I wanted to kind of highlight that there is a lot of behavioral kind of signals of how we live in the real world that is very valuable, right? And in real patient interviews and interviews with family members, we've also seen some of these things come up in terms of what happens when someone's mental health is declining, changes in sleep pattern, being socially isolated. As I mentioned, that my legs bounce, speech goes fast, so just real kind of changes in the rate of what we do things. So in this case, it was a patient who had mania. So there is an increase in terms of rate of speech and overall movement. When someone is depressed, we see the reverse. And sometimes loved ones can't pick up on those cues and also understand how the patient's kind of overall mental trajectory is going. But we can track a lot of these signals, and there are commercial tools now that are available to really easily get at some of the signals. I would say that they've been used in the research context quite a bit, but still how to integrate it into kind of clinical care and practice is still something that we are working towards. But the reality is that the questions that we ask patients to assess their behavior can now go from being short-term, like snapshot measurement or paper, or just like phone question answer setting where there is low adherence, to a continuous measurement. I think what is missing is how do we take that data and use it much more meaningfully in understanding kind of patient state and also in their treatment. And beyond just the phones that we can use to collect a lot of data, there are, of course, wearables and smart devices that are being used more and more to collect wider range of signals, but they can also be used in therapeutic interventions. So there are already solutions of chatbot-based CBT, but what is there also missing is sometimes the sensing and measurement is not integrated with some of these digital intervention tools. So the other thing I want to kind of mention, that there is a big gap in thinking about what can you measure continuously with these digital tools and how you intervene. And I think there is a big opportunity in trying to make that much more interconnected, and that's kind of what the title of my talk and what within my group that we've been trying to do is how do we really think about closing the sensing to intervention loop, and keeping in mind that there are limitation in patients' ability to do certain things. There is limitations in time aspect, like whether a clinician or a care team has the time to use those signals in treatment delivery. So there is also the need to think about it not beyond just the technology capability side, but also how does this information integrate in different stages and different kind of individual, like patients' lives, as well as how it can be used in a clinical context. But just to give you a little bit more kind of detail of what we mean by data, we already know with kind of smartphones, we can get that location data, we can get cell phone use data, we can get data from activity and accelerometer. But if we kind of delve down a little bit more, one level deeper, right? Like location data is not just GPS, right? And David and his group has done a lot of work also with this type of data, showing that you can look at whether someone stopped leaving their home, although this takes a very different meaning in this context of COVID, but changes in where their mobility pattern, whether they're going to work, how many places that they visit, how much diversity is there in those locations, and how much time are they spending home, can all be meaningful kind of signals. Similarly, kind of combining the location data and how they're using their phone, as well as accelerometer, you can get at sleep-wake data. So there are already a lot of wearables out there and also kind of connected devices that get good sleep measurement. But even just using the phone, we can get fairly reliable measurements on sleep duration, sleep interruptions, even going beyond to try to get at people's chronotype. And one of the kind of beliefs that we have is that if someone has wearables that are giving you much finer grained information, that's great. But a lot of people don't own wearables still, and there are the use pattern can be highly variable from person to person. So whereas phones people almost always carry with them, so there is the opportunity of getting broader coverage when you are using data that may be somewhat coarser than the special purpose wearables. So there is the advantage of trying to kind of get the maximal coverage, even if it's coarser signal, and then try to get finer resolution of data if you have special purpose wearable. And so sleep, I think, falls in that category. And if you think about smart devices, now something like the iOS with HealthKit, you can get the wearable information, but you also have the phone data. So it's really kind of makes it much easier to kind of think about combining information so that you can get coverage as well as resolution. And again, from the accelerometer data, you can look at number of steps and exercise bouts, but also one of the things that you can delve into is things that are very important in the context of mental health is these the psychomotor aspect, like walking rate. And we've seen that by looking at changes in walking rate for a person, there is correlation with how their mental health is changing. And you can get much more. This is an example that what is also important to kind of think about in this space is that you have all these raw data. What type of features are known to be correlated and informative about someone's mental health, and whether you can get it reliably at a fine grain or reliably at a coarser grain, what's needed with the usability aspects of it and the reliability aspects of it. So I think it's not something, and it may not be true for one, it's not definitely not one size fits all. So I think one of the way of getting at kind of at scale with high variability is thinking about how to kind of combine different types of information. And the next step comes to is that we can collect a lot of data, but those have to be summarized into things that both patients and on the clinical side, people can take action based on, right? So we often, so you have the initial kind of collection of data, and then there is, of course, some data cleaning and aggregation that needs to happen. One of the ways where we would try to kind of break it down is thinking about different aspects of behavior, the social, the physical, sleep, psychomotor, that have been shown to be clinically meaningful, and then use those to model disease-specific kind of trajectories. And our overall approach is that ultimately in these type of data is being collected, and unless a patient or the clinician need to take an action, that just happens in the background. And if there is a change or some action needs to be taken, you kind of expose the highest level of information and delve down as needed. And that's particularly kind of something that is important in some of the kind of collaborations in the clinical side, so that particularly if you are in a real kind of treatment context, that you don't want to overwhelm with data. So being overwhelmed with data is a serious concern, both from the patient and the clinical side. So I already kind of mentioned the various categories of behavior. One thing that we also very important in the context of mental health, and there hasn't been that much work on the technology side, but now it's happening more, is looking at substance use, because substance use oftentimes goes hand in hand with mental health issues. So that's one thing that is very important for us to think about. And I want to kind of also mention one of the things that over the years we've learned to be very, very important is that sometimes for research reasons where we publish and others, like our tendency is that we build the technology and then once it's, then we think about how can we scale up and deploy. And similarly, there is the needs from the clinical side as well to have a technology that is robust and reliable to deploy in a clinical study context and definitely broader. But I think one of the things that is important for us to think about is how do we actually do the technology development and some kind of deployment go hand in hand, because sometimes from a technology evolution point of view, we make choices that are done for the paper. We want to show high accuracy, but not paying as much attention to usability, longitudinal kind of data capture, which gets missed and gets exposed in the clinical side. By that time, to go back and fix the problems is much harder. So another thing is kind of for us to figure out, I think, as a community and the research side, is how do we do much more rapid iteration between kind of clinical deployment and technology, and many of us are starting to do kind of smaller pilot and iterations, but I think thinking about more of how we could do this iterative design is very, very important. And then one of the things that we have kind of over the years kind of concluded that the first the most useful bit of information that we can expose both from a patient and from a clinical side is to know, is there something that is bad happening, right? And what if everything is fine, you don't always have to think about patient engagement or clinical engagement. So the one thing that I think which is important in the context of scale and really making increasing access to people who don't have mental health access is, can we know when something bad's happening? So I want to kind of give an example of what we have been, how we have been thinking about it, right? So our goal is we can collect all this data. Can we predict behavior changes that precede a major psychiatric event? And in this case, I will go to like the specific context that we were looking at is in schizophrenia, but it can be generalized more broadly. And one of the challenges are that behaviors are different across different people. They're not consistent. And how do we create a model that can predict that across the board, right? So, and as you kind of see in the PHQ that I showed, right? So let's say 15, someone scores a 15 and they need clinical attention, but there's different ways of getting to 15, right? Someone might be because they've been socially isolated, low energy, poor sleep, and the other person might be different in terms of how they kind of got that. So different people can get to kind of their mental health declining, but their behaviors and symptoms would be different. So that's something that we have to take into account. And from a modeling side, that if we are trying to model that someone is declining, just knowing that someone's declining isn't enough. We want to know why, right? Why did the system or the model give that signal? So the one approach that we have been kind of using more in our recent work is kind of thinking about patients' behavior, that the behavior, kind of their baseline in terms of representing their state based on how their behavior is changing over time. And it's not the specifics of exactly how many hours are they sleeping, or exactly kind of how many different locations they visit, but it's how their behavior is changing. The delta of their behavior is changing over time, and how much of it is changing, right? Is it changing across the board? Is it changing along one dimension like sleep? And that there is commonality in those changes across people rather than the absolute value, right? So if someone's sleep is getting disrupted significantly and their mobility pattern is disrupted significantly, those are indicators of mental health problems, as opposed to the specific numbers of their sleep and location, right? And that kind of delta is much more consistent across the board, that can be used in from a machine learning perspective to look at significant deviations. So as I mentioned, the results I'm going to show is on the data set called Crosstech. It was done in collaboration with Andrew Campbell at Dartmouth, Joelle, who is now at University of Washington, and John Kane at Northwestern, where our goal was to see if we can detect mental health changes and specifically try to understand relapse in individuals with schizophrenia. A little bit overview of what we collected. These patients were diagnosed with schizophrenia or schizoaffective disorder, were within 12 months of hospitalization. And it was a 1-year data collection where we continuously collected passive smartphone data, as well as ecological momentary assessment. There were kind of questions about positive and negative symptoms that were collected 3 times a week, as well as they had a monthly doctor's visit. Overall, we collected a huge amount of data. There were 75 patients that we start with in each arm. Ultimately, we landed at 60 participants. We had a significant, I think there was some month cutoff of around like 8 or 9 months where we had their data. And these were the examples of the positive and negative symptoms, the EMA questions that we asked. So what we wanted to do is train kind of a neural network model, where we wanted to see is took what we call the days of relative health. So when we had the measures of when there was a kind of relapse episode, and in terms of their BPRS score, when they had days of relative health, we used a neural network model, which is an encoder-decoder model, which is trying to basically encode the behaviors from the signal and recreate those behavior, right? So if we train this model based on their days of relative health, and then they're not doing very well, if we have a recreated behavior of what we want to, what their day should look like, and the actual signal is very different, the hypothesis is that there will be a deviation between kind of the recreated behavior and the actual behavior that we see. And the hypothesis is that if someone is actually trending towards relapse, we will see a sustained deviation. So this is kind of what our data look like, and this is kind of across individuals, where the x-axis is days before relapse, where the 0 is where relapse happened, and y-axis is just showing the anomaly rate, which is kind of calculated based on those deviation from the days of relative health, of how much deviation is there. And what we can see is almost a month before the anomaly rate goes up. And here we are not looking at a specific behavior. We are just saying we have all these behavior. We're going to combine their kind of, we have individual anomalies, but overall we're going to combine them into their overall anomaly rate and see how they're changing. So different people, their aggregate anomaly rate can be contributed by different underlying behavior, but overall they might look like the same, they have the same intensity of anomalous behavior. So what we saw is that there was almost like a doubling in terms of anomalies 30 days before a relapse episode. So I think one of the things that is interesting kind of here is that you could now kind of hone in on the patients thinking that something is happening and there is a check-in needed. So in the context of actual, and the paper has much more details of actual kind of accuracy of these. There's still kind of false positives and false negatives, but one of the things is that we can actually kind of zone in into the patients who we think might be worth following up on. So that was, and that is something where we can now kind of train kind of models that are sensitive towards those individual differences without having it, and which we think will scale more broadly, as opposed to kind of having a data set and tuning it too much to that data set. But here we're just kind of trying to learn about the scale of differences. And of course, we kind of see changes, the underlying changes, some of the ones that were significant. You can see there was location in this data. We collected voice and ambient sound, as well as a kind of phone usage. One of the things that we also found is there were only very few cases where we had multiple relapse. I think only 6 or 7 patients who had more than one relapse episode. Overall, out of the 60, we had about 27. I think 27 relapse episode from 21 patients, and there were, I think, 6 multiple relapse cases. So what you can see here is the other interesting thing, what we were trying to look at is that for a given patient, do you have similar relapse signatures? So does someone have a relapse signature? And I think we still need more data to do that, but you can see that some of the behaviors is changing similarly in patients who have multiple relapse episodes. So that would be really interesting if individuals, we could start getting their relapse signature, but we have too little data to say that conclusively. There's some indication where we saw kind of consistency in the relapse pattern across multiple relapse episodes for a single kind of patient. So this is kind of one kind of thread of work that we are continuing, and we're also hoping to kind of one of the directions that we are going with this is, can this help us go towards creating models that work across data sets. So if you kind of think about all the work that we have done, and a lot of those that we spend a lot of time collecting rich data that is very time consuming, and we have some promising results, but oftentimes a model trained on a specific data set doesn't translate as well to a completely new data set. And some of the work that my current PhD student, kind of Dan Adler, is looking at is, can you take some of these approach and combine data set across different studies and trial, where some of the behavioral signals might be similar and the outcomes might be different, right? Like, can we actually combine a data set that was collected for depression as well as schizophrenia? The outcomes are different and we are modeling them differently, but the behaviors of sleep and activity and mobility, there might be some commonality or where we can leverage so that we can build more robust models. So I wanted to kind of mention some of our kind of thinking of where should we go next, because I think as a community, we really need to kind of go outside individual data sets and see, like, if we throw everyone's data together, where would we end up? The other kind of aspect which was important in this study, but we didn't really get to it to the extent that we wanted to, is this whole kind of notion of more synchronization between sensing and intervention. I think there is already a lot of apps out there that are separate in their own silos. So we need to kind of think about how there can be more data flow, because they even reside in the same phone, but there isn't enough data flow. But in the context of the schizophrenia study, we did something very simple. We actually, in part of our work, which I didn't go into the detail, we used the data to predict someone's PPRS score to look at how the kind of severity of the patient's kind of the patient's health, and had a cutoff point where if our prediction was greater than the cutoff score, in this case it was a PPRS score of 12, we would alert the physician or their care team. So before that, they got nothing. Right, they could access it if they need to, but there was no alert that was sent unless we knew that there was some kind of score. And the goal was to see if that there was a reach out, would we have fewer relapse in the experiment arm versus the treatment as usual arm. We didn't see that, but there are multiple reasons. We tried to build our model while this trial was going. So by the time we actually had a model that we could deploy, and this was not kind of as good as some of the results that I'm showing you. The time it was actually operational, it was 9 months into the study. So there wasn't that much time where that data could be used. And be used to see effectively whether it could be used in actually reducing the number of relapse. I still believe that we can do that, but I think kind of as we think about how to run those studies, I think also we need to kind of have time to do some model development, but also introduce intervention and think about what kind of time frame that we should think about designing those studies so that we have time to see the effect of some of these modeling in the intervention side. But ultimately, I think our overall kind of philosophy is that you can look at these disruptions in people's routines or rhythm and use that to drive intervention. I kind of mentioned that that I've been involved in kind of getting some of the results out there. So through HealthRhythms, which is the company that I've co-founded, and our goal there was to actually try to do that. So we had a strong clinical partnership. So Ellen Frank, who is an expert in kind of circadian rhythms, but also mood disorder and bipolar disorder, and also Mark Matthews, who has done a lot of work in terms of kind of user-centered design and user engagement. What we were working on research together, and that kind of led to the founding of the company, where the idea was that we have this continuous measurement. What if we use this to drive activity suggestion and also decide how we can deliver psychoeducational content that is relevant to the person at that time, and see if we did that sort of sensor-driven intervention, do we see an improvement in the patient's state. And this was done in a clinical trial that was done in partnership with patients undergoing treatment for depression at University of Utah, and where there was the treatment as usual arm, but they actually had just the data collection happening, but the other half actually got the intervention that was driven by the sensor information we got. So there we actually saw that there was if we use the sensor data to deliver more targeted intervention, we saw a decrease in kind of their PHQ score compared to their kind of treatment as usual. If we look at the baseline and after 16 weeks, I think there is a lot more opportunities to kind of think about how those interventions can be automated. Kind of what's the role of kind of automation versus human intervention? Whether some of the things can be also kind of thought about. Conversational agents and human agents and text-based systems. So this was kind of the first attempt at trying to glue everything together. But I think going forward, there's a lot of other questions that we need to answer to kind of think about it in a broader context. So I want to kind of, these were two concrete examples of the most kind of real world deployment that we have done. And I'm going to kind of step back and kind of talk a little bit more about intervention and how we think about interventions. So if we think about measurement, we had paper-based measures, then we did journaling on the phone, and now we're pretty much to a state where we have invisible measurement to a huge degree, right? So if we want to passively measure a user, we can do a lot of that in the background. But if we think about intervention, it still can put a lot of burden on the end user. And sometimes it's needed, right? You want the patient to reflect on their behavior, make a conscious choice. But should that be the only way to kind of approach intervention? And our thinking there is that there's technology allows us to actually try to kind of influence people's behavior in many, many different ways. And we still haven't really explored that as much as we should, right? We do messaging, we have chatbots, but beyond that, how can we, just like sensors have faded into the background, are there ways where we can leverage technology to better make very micro interventions that may not always require a lot of attention? And I think that is particularly important in mental health, because you can't always rely on users' kind of motivation and determination to make those changes. So I'll give you one example of the work that we did in kind of stress, real-time stress regulation. It's a project called Emotion Check, where the idea was that you now have smart watches that can measure heart rate, get at heart rate variability. You have accelerometer, you know whether the person is doing physically strenuous things. So let's say you know someone's heart rate's rising, possibly due to stress or anxiety. Now, you can now easily measure that. So let's assume that the person's heart's beating at 110 beats per minute. Now, your smartwatch, as well as being a sensing device, is also an actuation device, right? It vibrates. Let's say, and the different versions of smartwatches allow you different level of control. But let's say you vibrated very subtly, that it's kind of barely perceptible, and it reflected your heart rate. And that's kind of actually based on the ideas of people have used in terms of biofeedback and interoceptive awareness, right? People have some awareness of their bodily signals. This is a way to almost like make it a little bit more kind of on the surface, right? So kind of drawing the attention, but subtly enough that you don't have to kind of stop doing what you're doing. So let's say I'm getting stressed, I'm giving a talk, my phone, if it's very subtly vibrating, I probably still don't have to get too distracted. So instead of reflecting my real heart rate, what if it gave me false feedback, right? So my heart rate's rising. Instead of saying that it's beating at 110 beats per minute, the vibration actually is giving the signal of 60 beats per minute. Does that make any difference? And we did this kind of study in two ways. One, initially, we actually didn't tell the user it was false feedback. We just said that it was gave feedback on their heart rate. There was a second study where we actually said that the feedback may or may not reflect their real heart rate. So there was some ambiguity, but they actually knew that it may not reflect their heart rate. And then the first study was a traditional kind of social psychology 3-year stress test. The second study was done by doing a timed math test to look at, can we actually impact kind of how a given task. So in that case, there were individuals who were given these time tests, and we were measuring their heart rate, and we had a low feedback setting where we were giving a perception of their heart rate being lower than what it is, and a higher feedback where they were higher than what was. In the first study, we actually did just kind of neutral and a control condition where it wasn't associated with the heart rate. So if you're interested in those kind of benchmarks, it's there. But in the second study, once we validated that, we only looked at low and high. What we saw is in the low feedback setting, where the heart rate was low, the feedback was lower than the actual heart rate, the self-reported anxiety level was lower, and in the higher, kind of faster heart rate case, self-reported anxiety level was higher. Not only that, when we looked at heart rate variability, actually the physiological signal actually changed. In the slow heart rate feedback case, the heart rate variability increased, which is the direction you wanted to go if you are not as stressed, and then the slower fast feedback, the heart rate variability decreased. And the thing that we were excited about as well was they answered more questions correctly. So they were able to accurately answer more math questions when they had the slow feedback condition. We are actually taking this to look at whether we can use some of these approaches of anxiety and stress in the context of craving and craving mitigation. So oftentimes when someone's kind of anxious or stressed, they will resort to alcohol or other substances. And we just started, and I'm going to just show a picture, but it's not a real result. We just did a very small pilot of looking at alcohol consumptions, where we are trying to give that kind of feedback to see if we can reduce craving for alcohol. And again, this is very early on study, which, just to kind of give you an example, I wouldn't take anything out of this result other than that we're not seeing it completely reverse the results. We still need to do more work on this to see if it really works. But to give an example of how we are trying to take some of the results to kind of look at it, can we do some of these types of subtle intervention? And actually to go on that, we're simultaneously trying to build hardware and some sensors to be able to do measurement of alcohol and some craving signals. The craving signals that you see on the left is more for opioids. You can have like goosebumps, which is more specific to opioid consumption. So we're looking at how you can use various signals to get at consumption and craving, and then drive intervention as well. So the hope is that we can enable the future of integrated care by continuous measurement, but really being thoughtful about what we need to predict accurately, and how to deliver the intervention, and how to engage the patients, and how to engage the clinical clinical providers as well as caregivers, and do it in a cost-effective way. And I want to kind of also end by kind of saying that we have to think about certain pitfalls, right? As I said, that we don't have a lot of open data. I always kind of give the example where like fMRI studies used to be done in like 10, 15 people before like people got together and created like repositories, where now you have a lot more data sets of people. I think that's something that is still lacking, and something that kind of David and I have talked about, and hopefully we can get towards. Also, we have to be very careful about sensing and privacy. I think the ability to do a lot of on-device computation, there is a lot more research to be done, and also in the context of federated learning, machine learning, and others. But we have to be careful, because if you make it seem very creepy, then you're going to just lose people. And ultimately, we have to be also very thoughtful in terms of how much burden that we are putting it on the user, and also on the user as well as on the health system that is digesting that information, and what do they need to do about it. So with that, kind of some of these ideas and things that we've been thinking about are led to kind of an initiative that myself and a few other faculty have launched at Cornell Tech, called the Precision Behavioral Health Initiative, please visit the website if you're interested. We want to broaden the network of people and different stakeholders. So not just technologies, but not just also clinical researchers in terms of thinking about startups, insurance companies, health systems, that what kind of solution will really stick. So with that, I'm going to thank again students, collaborators, and also funders who have been involved in supporting some of the work. Let's see. I think I'll leave it there. Sorry. I'll pause now. Happy to take questions. I can also stop sharing.
Great, thank you, Tanzeem, for a terrific talk. We folks, if you have questions, go ahead and put them into the Q&A. We have one so far from Ellie Burgess. So she says, it seems to me there could be ways to combine observations from friends, family, caregivers around periods when individuals are declining, combined with sensed information from digital technologies. In my dissertation research, I found that observing changes in behavior, speech tone, facial expression, etc., prompted others to check in and see if the individual needed support. Do you see potential in tools that combine insights across human observations and technology sensing applications?
Thank you, Eleanor. Yes, absolutely. And I think the kind of more people that you include, the harder it gets to get data as well. So I think it's very, very important. We have done that in a limited kind of context in thinking about how do we bring data across individuals, and as you mentioned in your point, that different people are willing, like relationships are not like consistent across families or across groups of people, right? Some people might be more comfortable sharing with their friends, some might do it with their spouse, some might do it with their parents. And what we found that in order to even get that information, you have to first figure out who the right people are and whether everyone's comfortable and what even the burden that is placed. We did a little bit of studies in the context of student kind of mental health, and sometimes people were very resistant even sharing with their kind of close friends or getting their close friends involved because they think that's putting extra burden. So I think there's a lot of kind of social and relational aspects that one has to consider to do it right. I think the information is very valuable, but we haven't tackled that yet because it's a set of kind of going beyond like the user burden. How do you, without making slip ups, do that effectively across very different types of people? I think is a big problem yet, but great research problem to delve into further.
Okay, a second one here from Leonardo Bobadilla. Could you talk a little bit more about the psychophysiological data predicting or relating to subjective experiences of craving for substances?
Yeah, so again, I said that this is at a very early stage. So there are changes in kind of breathing rates and heart rate, often sweat, things that are indicative of cravings. There could be false positives as well. So in our context, what we are trying to do is, so actually my colleague at Cornell Tech, Raja Lakshmi Nandakumar, is looking at much more deeply in the measurement of these craving signals. It also varies. So there are certain things that are generic across different substances, but there are things that are more specific to certain like opioid use. So there are differences there. But one of the things that we are getting to is in the experiment that I showed, we use a known method of, so if you take someone's propensity for using alcohol, which was that audit survey, and then try to induce cravings, and those who are more reliant on alcohol should be more easily kind of, you can induce cravings. So there are certain protocols that you use where you ask them, in our case, where we ask them to kind of have a clear bottle of water, and if you sniff it, you know it's not alcohol, and then alcohol, and look at the changes in their physiological measurement. And then that's where the intervention was. So I think we need to kind of collect data of like how people's kind of physiological signals change in the presence of craving. We also did some data collection in the context of vaping to see how those signals changes. And then we also have the signal from an instrument and vape to know they actually vape. So there's ways that we still, there's more to be done into understanding which physiological signals are reliable measures for a person who is taking substance. So there's definitely signal there, but we haven't explored it in the wild product yet.
Okay, a question from Matthew Jersa. Amazing presentation and extremely innovative and eye-opening. I was wondering, what are the next steps for these findings? How are you going about scaling your startup as well as these evidence-based interventions? Do you have considerations considering the funding for mental health care is historically limited and primarily a huge burden for Medicaid?
Yes, it's a good question, and one thing that I didn't kind of disclose because it's kind of hot off the press, something that I'm really, really interested in. And as I said, I think there is an opportunity post-COVID where people are thinking about how do you scale. So I'm really interested in, so what the Precision Behavioral Health Initiative is one attempt of trying to bring very different people and not just researchers into the conversation. And thinking about what problems need to be solved for adoption. The other thing I've very recently started doing is actually I'm going to be working very closely with one of the major insurance companies in the US, United Health Group, where they are really interested in thinking about how technology plays a role in scaling and digital solutions in the remote patient context. So actually just this month, or like a week ago, I actually kind of started in some role, and I'm going to be ramping up some of my involvement in the next year to try to help figure out within a pair context how you can scale some of these solutions. And I absolutely believe that we need to do more of that if we want to. So from my perspective, if I do research on a technology and then 10 years later, someone looks at it, by that time, that technology is obsolete, right? So you have to, if you really want this research to matter, you have to kind of think broadly of how it could be used and a system for evolving with the technology, right? Right now, there isn't a system that those solutions evolve with the technology. So my hope is, and HealthRhythms itself is growing and trying to kind of build those partnerships, but also doing a startup. I think there has to be pull from the healthcare payer, like Medicaid, as you mentioned, but like if a company like United actually serves a lot of Medicare and Medicaid populations. So I think absolutely we need to, there has to be evangelists inside to kind of figure out how to get this done. But I do think now there is an appetite with, maybe that was one of the plus sides of COVID, that I think it's almost like really jolted the system out of kind of its slow, steady state to trying something different.
Okay, it looks like there's one in the chat here from David Ahern. So great presentation. Can you comment on how process sensor data can be mapped to specific intervention components in digital solutions?
So I think, for example, in how we did that, right? So if you can look at process sensor data and sleep is a big thing, like sleep irregularity and shifts in mental health, right? Like, so one of the things that with kind of in our work with Ellen Frank, where we wanted to like look at stabilizing sleep and aligning with their circadian rhythm, right? So people also use some certain types of like CBT type methods and other methods for sleep intervention. So if we can take this sleep signal to map it to kind of delivering kind of sleep behavior change. The other thing that we did in the context of activity also is if someone is kind of not doing too well kind of mentally, and you have you have data about how they actually got physically active, right? So asking them to go to the gym may not work, but if you know that they had like specific, even like a coffee route, or they took the bus to work instead, or subway to work and walked instead of taking an Uber, you can nudge them in a way that they have this notion of self-efficacy, that they have done it before, to drive that intervention. So there, you're not just saying you should go out and move, but you are actually tapping into their historical data and giving them specific suggestions of things they have done many, many times before, to say, how about you do this again? And you have already done that. So trying to combine, give them the feeling of self-efficacy and they have done it, rather than kind of suggesting something that seems very far off, is also useful.
All right, we're at the top of the hour, but maybe we'll squeeze, if you have a moment, we'll squeeze in one more, and then maybe, if it's okay, if people really want to ask their questions, they can contact you.
Sure.
So the last one here from Sarah Priam, you mentioned transfer between different conditions, e.g. Schizophrenia and Alzheimer's disease. In your experience, is it straightforward to transfer between different data sets from the same condition? Also, what do you see as the main challenges for transferring solutions across different data sets?
Yeah, so we haven't done, like, so we have now just started and actually working with David and trying to think about like taking, so there are some data sets that are already publicly available, right? Andrew Campbell has a student life data set, which is very different of looking at student mental health. We have the schizophrenia data set, David and Madhu, and they've collected a lot of data, depression. So the underlying behaviors that we are capturing are sometimes similar, right? Like we're capturing a lot of like the smartphone sensor data. And we know those certain behaviors like sleep, activity, and regularity and rhythms are important across those conditions for mental health. But how they change, the time scale might be different. So one of the things, and this is just something that we are working on, we have some initial results that is promising, but ask me in 6 months, I would say. But one of the things is that you want to leverage the commonalities in the data sets, but then have kind of the output layers to be kind of independent, right? So the outputs of like schizophrenia is different than if you're trying to do DPRS prediction versus PHQ prediction, right? Those outputs are different, but then you can still leverage the sensor data. So kind of looking at, in the notion of transfer learning, you have different output, but you have some common inputs. So that's what we are trying in the early stages. But I think if we start working together to collect the data, I think technically people have done that in computer vision. If you look at it, right, like people have actually combined very, very different. If you look at, people have combined data of images of things with sketches of things, right? So there certain shape features that are the same. It looks the same, but it's very, very different in terms of the output, right? One is a sketch and one is a photograph. You can kind of think about that, like that's the kind of general approach that we are taking, that there's a lot of things that are common, but one is a sketch and one is a photograph. We think about a PHQ and DPRS, and can we take some ideas that has been done much more scale in these kind of contexts, and apply it into our data sets. I think the biggest barrier is that we haven't shared data sets, right? And I think if we start doing that, I think that we can tackle some of these.
All right. Well, Tanzeem, thank you so much for a wonderful talk.
Thank you.
Always wonderful to catch up on what you're doing.
Thank you so much. Thank you. And yeah, feel free to email me. Just Google me. You'll find my email. It's tanzeem.choudhury@cornell.edu. Check out the Precision Behavioral Health website. And yeah, I'd love to continue the conversation.
Thank you. All right. And see you all next month. So Skip Rizzo will be talking next month on virtual reality. Thanks very much.
Thank you.
Bye.